So let's test your thing. You can share your screen and see how it works.
Can you hear me though?
I can hear you nicely. I can see.
Oh, okay.
Nice.
Okay.
Yeah. Yeah, I can see your first slide. Just maybe go to slide show mode and just see that it goes further. That's all.
Can you see properly from your side as well?
I can see your slide nicely. First slide.
Okay.
Yeah.
Okay. Okay. Yeah, everything is fine.
Yeah, that's fine. Slides are going forward. No problem.
Okay. Perfect.
Yeah, perfect.
Okay.
Now I can hear you nicely. So
okay. Yeah, because this laptop sometimes has issues with the microphone, so
okay,
it has tendencies of failing. Yeah.
Like it drops connection in between.
Yeah, but that's why I had my phone as backup, in case I lose some connection. So I'll log in as well with the phone.
Yeah.
Just in case I lose connection, then I can still continue from that side. Yeah.
No, but this is perfect.
Okay.
Connection, sound, everything is fine. So if you just stop screen share, then I will just share your intro. Sello, can you see my screen now? Or not yet?
No, I can see it, Prof.
You can see it, huh?
Yes, yes.
Yeah, okay. I think we'll start now, just after 5 o'clock. Good afternoon, everybody. Or good morning, good evening, wherever you are from. Today, Dr. Sello Machaea is going to give us a talk about gastroschisis in the developing world. Dr. Machaea is a consultant pediatric surgeon in our Department of Pediatric Surgery at Frere and Cecilia Makiwane Hospitals in East London, in the Eastern Cape province of South Africa. And he is a senior lecturer in the Department of Pediatric Surgery at the Walter Sisulu University in South Africa. Dr. Machaea did his MB-CHB from the University of KwaZulu-Natal in 2007. He underwent training in general surgery in KwaZulu-Natal between 2011 and 2014. And I'm proud to say that he did entire pediatric surgery training in our department from 2015 to 2019. He succeeded in fellowship in pediatric surgery from the College of Medicine in 2018, and he has completed his dissertation, which is on gastroschisis in the Eastern Cape. And I think it's just a few days from now, he should be receiving his M.Med degree. He's also a registered PhD student with the Walter Sisulu University, and it is a South Africa and UK initiative. Dr. Machaea has a special interest in minimally invasive surgery, gastrointestinal and hepatobiliary surgery, and he is very keen in teaching and training under and postgraduate students in our university. I know personally he's a devoted family man, and he says he loves traveling and his wine. I didn't ask him whether it was the white or the red wine, but he can tell us that. So I invite now Dr. Sello Machaea to give his talk about gastroschisis in the developing world. Sello, I'll stop sharing in a minute. Okay, Sello, I'm glad to see that we have experts from certainly all over Africa, but I'm sure outside Africa. And Dr. John Sekabira, who has written a lot about gastroschisis from the lower and middle income countries, has also found time to join our meeting. So Sello, please go ahead. Thank you.
Hi, thanks, Prof. I'm not fussy about which one, but I do have a case of having white. And as you can see in the picture, it's a bit of a bubbly day. But either way, good day, everyone. I'm Dr. Machaea. I'll just be talking about gastroschisis in our current environment. Some disclaimers. There is no monetary compensation for me doing this talk. Images used were with permission from the authors. And I'm definitely not an expert in the topic, just have quite a bit of an interest in it. So the outline of the talk, I'm just gonna just talk briefly on what gastroschisis is, some developmental theories, the epidemiology, if it has changed or not, the associated risk factors with gastroschisis, its management and its prognosis. Then just give like a few slide presentation on my actual dissertation.
Sello, sorry to interrupt you. Maybe just get a little closer to your microphone and talk a little bit slowly.
Sure. Gastroschisis is one in a spectrum of congenital abdominal wall defects. Typically, the abdominal wall defect lies to the right of the umbilical cord insertion, with varying amounts of uncovered intestines protruding through the defect. Unlike our fellow CO, gastroschisis has fewer associated anomalies. The main anomaly being intestinal atresia, which affects roughly about 15 to 28% of the neonates. Gastroschisis can be classified as either being simple or complex. Simple gastroschisis basically entailing an abnormally protruding uncovered bowel with no other associated gastrointestinal tract pathology, whereas complex gastroschisis entails added pathology such as necrosis, perforation, atresia, or even a volvulus. Complex gastroschisis usually infers a much higher morbidity and mortality than a simple one. Although the cause of gastroschisis is unknown, 5 main embryologic hypotheses have been proposed, from failure of mesoderm to form in the body wall to rupture of the amnion around the umbilical ring with subsequent radiation of the bowel, abnormal involution of the right umbilical vein leading to weakness of the body wall and gut herniation, disruption of the right vitelline artery with subsequent body wall damage and gut herniation, and lastly, abnormal body wall folding. Gastroschisis has a prevalence of 2 to 4 per 10,000 live births, with reported increased incidence both locally and internationally. The highest incidence being reported in mothers less than 90 years of age, and an evenly distributed male to female ratio. Though in the South African context, there's a slight female preponderance has been demonstrated. The risk factors for developing gastroschisis include a young maternal age, typically below 19 years of age, ones with much lower body mass index, signifying some malnutrition, those from a lower socioeconomic status, maternal race, though this is more of a geographic factor. In my particular study, more than 90% of the patients were of the African descent. So this one is more of an international study saying whites affected more than blacks. Maternal use of substances, cigarette smoking, use of cocaine and amphetamines and alcohol abuse all have been associated risk factors for the child having gastroschisis. Also, the prescription of over-the-counter medications such as aspirin is a huge risk. If the mother contracted a urinary tract infection while pregnant, this has also been shown to be a risk factor. The management of gastroschisis starts from the antenatal period with a confirmatory ultrasound performed by visualizing an irregularity of the anterior abdominal wall and hypochoric loops protruding lateral to where a normally inserted umbilical cord would be. I'm sure you can see it a bit, but you can see that this ultrasound just depicts some dilated groups of bowel, which were identified antenatally with a diagnosed gastroschisis. This just shows that we require to highlight that we need to follow up these kidneys. Once we see that they have gastroschisis, once we have identified that they have some underlying pathology that dilated groups of bowel, we need to subsequently follow them up with serial sonography so that we can be able to assess the degree of dilatation. It's been shown that neonatal fetuses with a dilated loop more than 20 millimeters don't fare out so well in the end. There has been much debate as to the appropriate mode of delivery and at which gestational age a fetus diagnosed with gastroschisis must be delivered. Some authors advocating for a planned cesarean section, which has been found to be associated with a higher rate of primary closure, shorter duration of mechanical ventilation, earlier establishment of full enteral feed, and a shorter hospital stay in preterm infants. But at the same time, other studies have also shown no benefit or even a poor outcome in performing cesarean section for preterm fetus compared to term deliveries. The current literature, though, does state that routine cesarean section should not be performed in fetuses with gastroschisis unless if there is an obstetric indication to perform the maneuver. At birth, gastroschisis management is basically aimed at preventing desiccation of the bowel, heat and fluid loss, and this is done by wrapping the eviscerated bowel with cling wrap or any available sterile medium and initiating intravenous fluids. As we know, in some developing countries, we don't have easy access to a preformed silo. So cling wrap is our go-to gadget to actually try and cover the bowel, or we actually fashion our own silo by taking a 50 or 200 ml saline bag and cutting it at the bottom, removing the fluid, and actually using the bag as a silo and securing it onto the sheet if feasible. The other way of managing is we want the aim of management is to prevent infection by initiating broad spectrum antibiotics in these children. We want to also prevent ischemia or traumatic injury to the intestine. This you can do by widening the abdominal wall defect if you find that it's a bit strangulated. And also it's very important to practice meticulous handling of the bowel as to not cause further insult to the bowel and further increase the chance of sepsis by not handling it in a clean way. The one other avenue that we do with these kiddies, we want to decompress the GIT. So we insert an oral gastric tube and leave it on free drainage. And what also helps us with the reduction of the bowel is via giving a rectal washout to decompress some of the mucosa that's in there. The aim of surgical treatment for gastroschisis is to restore the integrity of the anterior abdominal wall and reduce the herniated viscera within the abdominal cavity. Operative options include primary reduction of bowel with operative closure of the fascia, silo placement followed with serial reduction of bowel and eventually delayed facial closure, and lastly, primary or delayed reduction without any facial closure. Primary facial closure remains the preferred method of gastroschisis repair in our European counterparts. We also aim at attaining primary facial closure, may be delayed because of other compounding factors which are beyond the treating facility's control. But the primary aim is to close the fascia. And sometimes when we are battling or challenged a bit, especially with a child who comes in hemodynamically unstable, for us to even consider taking to theatre to perform such a tactic, we opt for more of a silo placement and serial reduction. And this allows the child's abdominal girth to actually increase, and while we are subsequently also resuscitating the child at the same time. So it's like a hand-in-hand way of handling the child. In the 60s, Schussner first described the creation of a silo from patients in whom there was visceral abdominal disproportion, allowing for a gradual return of the viscera into the abdomen and a natural dilatation of the abdominal wall in 1 or 2 days without compromising on the respiratory or the hemodynamic status of the patient. Thereafter followed with primary closure. The one I think we're more familiar with is Yankee and Dixon, who also showed that we can perform a delayed reduction without any sedation or anesthesia. On the images down your left, it's silo placement, which is strapped down to the interior abdominal wall of the child as to allow for severe reduction with that clamp or that rubber device at the very top. And the image on the right just showed just the child is almost ready for closure of the fascia. What we want is for none of the bowel to be protruding past the abdominal wall. Once it's flat, like in the image to your right, we know that we can attempt to close the fascia. There may be problems with closing the fascia. I'll just show you another tactic of overcoming that. Ribbo also described a sutureless closure of uncomplicated gastroschisis by using preserved umbilical cord and pulling it to the contralateral side, thereby opposing the skin edges over the reduced bowel, then applying some form of adhesive dressing to keep it intact. This is another way of trying to close defects. You find that you have reduced quite a lot of bowel into the abdomen, but the defect itself is quite large. And as you try to close the sheath, you find that it's increasing the airway pressures of the child, and it's ultimately going to cause compartment syndrome, which we do not want. So what Dirk recommended, we did a case report on this, recommended putting in a composite mesh in these gastroschisis with quite a big defect. What can be done as well is, which we sometimes practice at my institution, is we try to close the defect. If we can't, we actually just apply a VEC dressing over the defect itself and allow it to granulate. And over time, we apply a skin graft over it. A huge contrast in mortality rates exists between developed and developing countries due to the lack of infrastructure, specialized care, and specialized goods. In developed countries, we see a mortality rate of 4 to 8%, whereas in developing countries such as South Africa and Zimbabwe, a higher mortality rate of 65 and 84% have been reported respectively. Other than the country where the neonate is born, other factors play a role in the outcome, such as whether the patient was born in the treaty facility and was able to receive prompt neonatal and surgical care, or whether they were born outside the treaty facility and required transfer to the definitive facility. The degree of injury to the bowel, immediate post-operative recovery, availability of surgical care in a prompt fashion, preferably within the first 10 to 12 hours of birth, early post-operative extubation, and early enteral feeding all play a role in helping towards having a good outcome in the neonate. When it comes to my setting now in the Eastern Cape, we have a population of roughly about 7 million, and about 2.5 million of these inhabitants are a pediatric group. So we have quite a huge population to actually cater to for problems. This huge area is serviced by 3 tertiary facilities, Nelson Mandela Academic, which is in Umtata, Dora Nginza, which is in Gqeberha. Those who don't know where Gqeberha is, it's in Port Elizabeth, that's in UNAID, and Frey Hospital, which is here in East London. There's a total pool of 7 pediatric surgeons within the public sector here, and just 1 in the private sector. A retrospective observational study was conducted over a 3-year period in these facilities with the aim to analyze data on all neonates with gastroschisis who presented to the hospitals. 37 of these neonates were included in the study, with 6 being excluded due to incomplete records. What was found in the study was a higher female preponderance, mean birth weight of 2.1 kg, and a remarkable achievement of attaining primary closure within the first 24 hours. What was alarming, though, was the high rate of outborn deliveries. Out of the cohort of 37 patients, none, unfortunately, had a prenatal diagnosis of gastroschisis. So adequate planning for mode of delivery, place of delivery, and postnatal care plan could not be formulated. The mortality rate was also remarkably high within the cohort, which is much lower than reported in the developed world of 65 and 84, but still remarkably high. And the other one funny thing about this is majority of these kids being outborn, you would expect almost a higher mortality because they weren't born in the treating facility and they needed to be transferred out. But what was noted in one study that Setabera did in Albert Ituli, we found also that there were the diagnosis, intrauterine diagnosis of gastroschisis was also low. And out of the inborn kids that they had, quite a large proportion of those still demised. So his study kind of reflected mine in the sense that the inborn kids did not do far better than the outborn kids. Certain factors were found to be adverse contributing to mortality, such as being inborn, in my instance, being born by a cesarean section, and a high maternal age. The small sample size may have inadvertently caused the type 2 error and made the findings not statistically significant when it comes to this, because the sample pool was only 37 patients. The leading cause of death in this cohort was sepsis, which is universal. About 85% of the kiddies died from sepsis, with also others demising from hypothermia and dead bowel, and others having multiple anomalies which were incompatible with life. The Kaplan-Meier survival analysis graph just shows a 46% survival at day 28 of life of the neonates in this cohort, with the majority demising within the first 3 weeks of life. So in short, gastroschisis has a favorable outcome in developed countries, but remains a significant challenge in developing countries. With an advert of improving antenatal care and being able to diagnose gastroschisis early, a better outcome can be attained. But an improvement in the facilities, increased number of surgeons and skilled anesthetists, and ease of availability of total parenteral nutrition will steer both in the same direction as what we're seeing in the developed world, where they have very low mortality rates. That's all. Thanks, Bob.
Sello, thank you very much. This was quite short, but you covered it comprehensively. Before I invite comments and advice from other attending senior colleagues, there is a question from Dr. Chipo Mbeba. Please elaborate more on how you widen the defect. Is there a specific area where you place your incision? So maybe you can answer that question, Sello.
Sure. So it all depends, because other centers would go along the midline and just extend it further cranially. Other centers, they start off by giving the child some sedation and literally just putting the fingers within the defects and gentle stretching. So if gentle stretching is not feasible, then you can just extend your incision in a in a caudal fashion so that you don't actually cause obliteration there.
Sello, one more question I want to ask you from your knowledge and reading. I seem to feel anecdotally increased incidence of gastroschisis during the past 18 months of COVID pandemic. And I sort of hypothesize where the COVID vasculopathy is causing any vascular compromise to the development of the abdominal wall, resulting into gastroschisis. I haven't found any specific references. Maybe it is too soon, but what do you think about this?
Yeah, I've actually looked into that, and there's nothing currently mentioned about that. But as you know, with gastroschisis having that 15 to 28% risk of having atresia, which is atresias are more vascular pathology, and with COVID having this vascular path, we can kind of infer that it may slightly contribute. And definitely in our setting, within the past 18 months, as you said, we've seen quite a remarkable increase in the number of gastroschisis we've seen here. The only letdown is that we have not necessarily tested the mom, so we can't fully say that COVID-19 had a role to play here. Had we actually tested the mom and checked for antibodies, then you could have kind of said, okay, the moms had antibodies to COVID-19 and the child has some vasculopathy. So maybe one goes with the other, yeah, but definitely nothing is out there currently, but it's something interesting. Probably will develop within the next few years and we'll see what comes out from there.
Yes, no, I agree. Thank you, Sello. Sello, one more thing I would just like to share with the rest of our colleagues is that it is a bit, whether it is unfortunate or concerning, that we have been practicing for over 25, almost 26 years here in East London. And unfortunately, even after those many years, majority of the deaths due to gastroschisis or in patients with gastroschisis is because of sepsis. And that, I don't know how we can reduce that. Do you have any advice, any suggestion how we can reduce sepsis and morbidity and mortality associated with due to sepsis in gastroschisis?
I think it comes from delivery. If we antenatally we already expect the child to have gastroschisis and gets delivered in a facility where operative care can be given quickly, we find that there's less handling of the child. What happens is a child is born 400 kilometers away from us. They deliver the child, they handle the child in a not so clean way per se, and there's a lot of bowel manipulation that happens. And en route, even the way they cover the viscera might not be the best way to cover it at that time. Then by the time the child gets here, is already behind on fluids, is unstable hemodynamically, which needs resusc, which also gives the child a setback. So ultimately, should the child be born in a facility which caters or can handle gastroschisis early, that would ultimately help with these. As much as we try to be as aseptic as possible, particularly with how we put in our central lines and try to have good central line care, which is rather pivotal, because sepsis might not just be from manipulation of the bowel and from stimulation in that fashion. It's most likely from the instrumentation and the tubes, which is either endotracheal tube for ventilation, resulting in ventilator-associated pneumonia, or even the central lines that we put in, which cause central line sepsis. So it's a rather multifactorial problem that we face. But what the first worlds do, and how I infer that the outcome is better, is that they all delivered in, or majority of them are delivered inborn, and very minimal handling of the viscera, particularly by people not experienced. So it's experienced people who would be handling the child and would expedite treatment thereof. Because realistically, in developing countries, it's someone who's very junior, who may not have even seen gastroschisis in their life, and they're expected to give the initial management of this neonate and transfer in a safe fashion 400 kilometers away. So yeah, it's a sad reality that we have, but it's something that starts off by diagnosing gastroschisis intimately, and it will kind of help expedite things a little bit better.
Yes, Sello, thank you. I fully agree with you. I think those colleagues in private practice, even here, either in East London or in our country, will agree that majority of gastroschisis who get delivered in the private setup, they have antenatal diagnosis, and in addition to their obstetrician doing the ultrasound, they would get an ultrasound done by a specialist obstetrician so that they can even decide about the prognosis. And obviously then there will be a planned delivery and immediate careful aseptic handling of the bowel. And I mean, we, especially in the Eastern Cape, we are still far behind with respect of the antenatal care. And that is why we do not get them referred, because I remember in the 26 years, probably about half a dozen mothers have been referred to us in our state hospitals with a diagnosis of gastroschisis, maybe even less. And I think that contributes a lot to the morbidity and also mortality. So I will now invite comments from other senior colleagues attending the meeting. I'll, I think, invite Professor Hadley first. Prof. Hadley, your comments?
Hi, yeah, hi, Milan. Yeah, one or two comments. I think we all agree that January the 1st is a bad day to get sick, because January the 1st, we were always blessed with completely new trainees. And for reasons that are lost in the mists of time, I always put myself on call on January the 1st. And I can remember a new trainee arriving, and by 8 o'clock in the morning, he had been called down to the neonatal nursery to see a gastroschisis baby who had just been delivered. He had never seen anything like this before in his life. He'd never heard of anything like this. And so he made a diagnosis of an accessory umbilicus and ligated it at its base. Fortunately, he was not a very good technical surgeon either, and his ligature was not tight enough to strangulate the bowels. So we were able to salvage the situation. But Dr. Machaea is quite right that the people who are often seeing these are seeing their first ever gastroschisis, and that leads to frequent management errors. I'd also like to ask whether we have any Liverpool supporters in the audience, because if there are, they will remember a famous Liverpool player called Jamie Carragher. And Jamie Carragher was quite an interesting character. His mother had an antenatal diagnosis of gastroschisis made late in pregnancy and was offered in those days a termination. Because they were Roman Catholic, they declined the termination. And so Jamie Carragher was born with a gastroschisis. And if you look at his abdomen now, you can see that in those days, fixing a gastroschisis was not easy. And he had multiple flaps, and he's got a scarred abdomen, the like of which is probably unrivaled. So even in the days before TPN, gastroschisis was survivable, but it was a difficult problem. I'm going to bow to John Sekabira, who's got far more intimate knowledge of the figures that we produce from Durban. But just to say that one common cause in our practice of trauma to the bowel in a gastroschisis is the umbilical clamp. and that the bowel just rests on it, or is bound up in this cling film dressing with the umbilical clamp on it, and it causes a pressure necrosis of the bowel wall. Take off the umbilical clamp and nurse the baby on his side so that the baby's safe from the aspiration. And of course, during any operative procedure, you've got to be acutely aware of the abdominal compartment syndrome, which I think is probably a more sinister snake in the grass than we acknowledge. And we've been measuring the intra-abdominal pressures of these children with a transvesical catheter, and the absolute numbers mean nothing, but you've got to watch the trend. And intraoperatively, you've got to have the gentle hand of an experienced anaesthetist on the bag, testing the resistance to ventilation. But any question of doubt should stop any attempt at further reduction. Yeah, I think that's about it. I'd just like to thank Dr. Machaea. I think it was a very nice summation of the current state of play. Thanks very much indeed.
Thank you, Prof. Hadley. I'm glad that you have mentioned about the umbilical clamp, the plastic clamp especially, and the compartment syndrome. I remember a case while we were in Glasgow where a newborn had a primary closure and developed abdominal compartment syndrome. And unfortunately, the abdominal wall was not reopened immediately. The resuscitation was continued, and things like THAM were given for persistent metabolic acidosis. And I remember that baby died. So abdominal compartment syndrome is a reality and is a serious problem. I may not have heard, Dr. Machaea might have mentioned that for the juniors who are attending this meeting, please do not apply or cover the exposed bowel with wet gauze. That is detrimental. Just get some plastic which is, if possible, sterile, if not possible, as clean as possible. Cling wrap is the best, but if not, just get any plastic bag, like a bag of a rice tube or urinary bag or anything like that, and just cover the bowel to avoid heat loss. Now I will invite Dr. John Sekabira, and most of us know Dr. Sekabira. Dr. Sekabira is a senior pediatric surgeon in Uganda, and he has done a lot of studies and published in the scientific literature about comparison between the minimal mortality in the developed world versus maximum mortality in Africa. So John, please give your comments.
Thank you, Lily, and good evening, everyone, or good morning, wherever you are. Maybe what I would like to say, as Prof. Hadley used to emphasize, is that when you don't antenatally diagnose gastroschisis, as is the case in Africa, then the train or bus has left you. The best way would be antenatal diagnosis and then antenatal transfer to a tertiary hospital, whereby controlled delivery can be done, and then further, the baby can be probably saved, rather than waiting a baby to be delivered in a peripheral facility, and then bowel usually is covered with the gauze, as is the case, however much you try. The problem is our textbooks, even Ashcraft, still writes covering bowel with gauze, and even there is a textbook of surgery in Africa. They also write covering with gauze. So unless we change the narrative, that practice still continues all over Africa. And then the other way we injure bowel is by kinking the opening is very narrow. So when the bowel kinks and injures, like kinks the mesenteric vessels, you find the bowel becomes even more edematous, and there is usually ischemia at the mesenteric edges of the bowel, small bowel. So you find sometimes even bowel becomes necrotic. So I think if we can fight that, then bowel, if the baby can reach safely when they are resuscitated and warmed, the problem is that when these babies are born in a peripheral facility, most of the people, because of what Dr. Machaea said, they see these babies for the first time, they get scared, and just from delivery, they scoop these babies on the first moving ambulance without any due consideration of resuscitation, warming, even clearing the airway, and IV fluids, and even placement of the NG tube. When they reach the tertiary hospitals, when they have aspirated, they have aspiration pneumonia, they have already contaminated the bowel is septic. Whatever you do in a tertiary hospital, you are just chasing after events. When sepsis sets in, when the baby is cold and hypothermic and acidotic, most of the time, whatever you do, you are just trying something which might not succeed. So I think the bottom line is to have them delivered in the tertiary hospital so that we don't have that problem. Maybe something which we have been trying here to advocate, especially those who are inborn, is to have a long umbilicus. And we use the Bianchi method, which I think most of you might have read about. This is Dr. Bianchi, the one who was practicing in Manchester. And I think now he's retired. He's the one who publicized that use of the umbilicus. You split it and make it into a rectangle and widen the defect. And when you reduce, actually what we are doing now here in Kampala, we are no longer giving these babies an anesthesia. We do it under local anesthetic. We just use local anesthetic where we widen the incision longitudinally in the midline. And after that, when you reduce the bowel, whatever much you can reduce, you can gauge whether the child is developing intra-abdominal pressure. When the baby stops like crying, the baby becomes even, the good thing is that when the baby is awake, you can see all this on your eyes, and you stop when you see that the baby is becoming breathless, or when you see that there is even the cyanosis comes in, and then you stop. Or if the baby becomes pale, that the peripheral perfusion is not adequate, then you stop. And then switch a plastic bag onto the fascia without preserving the skin. But otherwise, the umbilicus is a very good material which you can use to cover the bowel without causing too much intra-abdominal pressure. And of course, the urinary catheter is very important and dilating the anus so that evacuate most of the meconium. And that way we have managed to reduce mortality to around 60%. Our survival is now around 40% from the 90s, which we had before, which to me is, I think, success, because we don't have total parental nutrition and we don't have a NICU. So, okay, now a NICU is there, but we don't have the personnel to look after these babies. So to me, 40% is some kind of success, though you can't celebrate it as like in developed countries. And probably the other thing is trying to feed them early as much as you can. We put maternal breast milk on a piece of gauze and we start trophic feeds. Much of it might probably be absorbed, and as you aspirate to prevent aspiration. And recently, someone managed to get us some laparoscopic delivery bags, which can work as a silo, which you don't need to switch it. It encases very well like a synthetic silo, pre-synthetic silo. And when you anchor it, that one you can tie it gradually, and it works very well. And I think that way we are yet to see our results, but we are getting more successes with that. I think that's what I can say. Thank you.
John, thank you very much. I think it is, we do need to acknowledge and in fact congratulate you for being able to decrease the mortality in Kampala from 90 or 94% as per your old publication to about 60% without the availability of total parenteral nutrition and neonatal intensive care and or ventilation. So that itself, there are lots of lessons for us to learn here in Africa and in all lower and middle income countries. So thank you, John, for your participation and sharing your experience. Dr. Machaea, there are about 3 or 4 related questions from Dr. Machaea, who is joining from Kenya. So I think if you can just answer one after the other,
Sure,
those are
sure.
mainly related to how do you feed and what is our feeding schedule.
Thanks, Rob. I'll start slightly higher with Dr. Gohill.
Yeah.
I
Yes.
see, yeah. Was asking when we intra-op, is there an objective way to know if we can close primarily or not? And as you're saying, the main aim is to try and close the intra-abdominal wall without causing raised intra-abdominal pressure. So the one parameter that I use, which is right there in front of you, is you look at the airway pressure on the anesthetic machine. Preoperatively, you'll find that the airway pressure is sitting at 15. As you close the sheath, you find that the airway pressure shoots up to 25, 28. It's already a problem. So you don't want to have the anesthetist battling with ventilating the child, and you definitely don't want the child to go to ICU with such increased pressures. That's the one easiest way. The other way is if you find that the defect is bigger than you anticipated, and you try to bring the sheet from one side to the other side, and it just doesn't come across. That's when one option you can do, which I've done, is instead of closing the sheet, I just mobilize the skin and close the skin on its own. The child has a ventral hernia, but this can be repaired later. If you have facilities of putting in mesh, that's another avenue where you can put in a mesh in between the sheets. The other avenue as well, which is what we recently started doing, is put a vacuum dressing over the wound and try to help with granulation and wound kind of contracts, then you can graft over it. With Dr. Machaea, he's asking, and he's asking about the TPN, which is better, TPN, breast milk, formula, and when to transition to nasogastric or oral feeds. Well, breast is always best, and that's what we definitely encourage. But we know that there's some form of dysmotility initially with these children. They've been exposed to amniotic fluid for quite a long time, so we don't expect them to start having established enteral feeds soon. So we have our protocol is to put Centraline on all the children, start them off on total parenteral nutrition, and supplement that with trophy feeds. Trophy feeds has nothing to do with feeding the child at all, has no nutritional value. It's just to feed the enterocytes in the GIT. And we look at the aspirates. Aspirates, we're looking almost at on a trend. We're not looking at a static number of saying 100, okay, you can start off 50. We start off by, let's say a child has aspirates of 100, and over a course of 2-3 days, they start going down to 80, 70. It's telling us that the GIT is working. What even fantastic is if the child passes through or passes some podium, then it's reassuring. But you look at the trend, you want to have a decrease in your aspirate volume to initiate feeds, because you initiate feeds too early, you run the risk of the child aspirating, vomiting and aspirating. So that's why we definitely don't rush. I can't give you an exact figure of saying, okay, if the gastric aspirates are this number, then you can start oral feeds. But the trend is more important. The child is stable, the aspirates are coming down. That's more important, especially when you start trophic feeds and start slowly increasing the feeds. We start trophic feeds generally about 3 mils, 3 hourly, which is quite a very small amount. Then slowly increase up there until we get to full feeds. It doesn't necessarily have to happen over a week. for us, it happens over a course of 2 weeks, sometimes even 3. And at that time, when we nearing the two-week mark, we already start suspecting that there may be other pathologies associated, like atresia. And that's when we start thinking that we have to investigate, do a million follow-through to see and determine the actual pathology, because with the distal atresia that you did not see as you were putting the bowel in, the aspirates will persistently stay up and they'll never ever come down. So these children, we just keep them on TPN, make sure that we cycle the TPN for those who have SMOF, start SMOF early and avoid IFL. And we find that it works. And we try to keep the central line as clean as possible, because we know we will need it for a more prolonged period of time. Then once the kids, we've diagnosed an atresia, then we plan our management, and we generally plan to repair the atresia when the child is about 6 weeks old. We don't repair the atresia when the child is still early at 2 weeks. We've had some unfortunate outcomes from that, with causing quite extensive serological tears and fistulas. So we have a tendency of just waiting until the child is a bit older.
So there's an interesting comment from Dr. Sekabira that he has also seen increased incidence of gastroschisis during the COVID pandemic, and currently 11 out of 40 patients in his ward, that's 25% of patients, are of gastroschisis. So I think it is going to come in the next few years, the relationship of gastroschisis and maybe even bowel atresias to COVID. But if you can answer question by Dr. N about the long-term follow-up and the central lines which we insert.
So Dr. N asked, what's your long-term follow-up on umbilical hernia? I assume this is like a ventral hernia that we get for those that you don't close the fascia in the neonatal fluid. And which central line do you put in, or IJ? Okay. So generally, closing the ventral hernia will be more for cosmesis, because the defect is so huge. The chances of it strangulating slim to none. So it's more of a cosmesis effect, and we definitely wait until the child is thriving and nutritionally well. I would not try and fix anything before the child is a year old. I'd let them grow, let them thrive, then consider fixing it there. The central line we put in, we do a cut down of the right internal jugular. Why we have a tendency of doing a cut down is because we can actually tunnel the line. Other centers may have Roviac lines, which are very small, which is what other centers use for chemotherapy. It's a very nice gadget to have, and you can easily tunnel it. And we found that the lines that we actually tunnel have a less chance of becoming septic versus the line which is just going straight into the particular vein. So tunneling a line in our setting seems to help quite remarkably.
Thank you, Sello. I would now ask Dr. Yashoda Manikchand, our consultant pediatric surgeon in our department, to give her comments. Yashoda.
Hi, Prof. Yes, thanks to Sello and thanks to John and Prof. Hadley for all your comments. I just want to, I think everyone made it very clear that if you want to differentiate between a developed country and a developing country, just look at the mortality of gastroschisis, because it tells you a lot about the late presentations, the lack of antenatal care, and the state of our neonatal ICU care. And that's also where the sepsis probably comes from, all three of those factors. I just wanted to know if anybody has looked at the condition of the bowel itself, not necessarily necrosis or atresia, but just the condition of the bowel, whether there's peel and whether it's dilated bowel, and how that affects the prognosis. So I don't know if Sello has seen anything to that effect.
For the dilatation, as I said, if they even found the dilatation intrauterine on the antenatal scans, kind of as a a bad prognosis. Maybe has to do with some element of dysmotility. I'm not sure, because as much as they have dilated loops of bowel, there's no evident atresia or stenosis in that particular limb of bowel. So dilatation maybe has to do with some form of dysfunctional bowel, dysfunctional motility, especially with it being exposed to amniotic fluid for such a prolonged period of time. And the peel may also be part and parcel with the exposure of the bowel to the amniotic fluid. And what even makes it worse is, as much as meconium is sterile, intrauterine, that's also things that can contribute to that, because the more delayed PDs who come to our center, other than desiccation of the bowel and frivolous manipulation, they end up having this peel. The fresh kids that you see within half an hour of being born, they generally have very little to no peel in them. Maybe it has to do with the duration post-delivery, as to how quickly the peel happens and as to what contributes to the peel happening. That would probably be a multifactorial thing. Thanks.
Yeah, I would say that the peel is probably from exposure to the amniotic fluid, but also exposure outside, like you say. So I think, yes, I think it does affect the motility of the bowel, and possibly the translocation and sepsis that we see in these kids that's not coming from somewhere else, it's coming from the GI tract. So it's something maybe we should look at to show, if there's a different prognosis for them. And then just to agree, I think, with Prof. Hadley about this whole COVID thing, it's not just COVID that has been a factor in the last year or so. It's also been an increase in anxiety, an increase in malnutrition, probably poverty. So there's a lot of environmental factors to take into consideration also. Okay, thank you.
Thank you, Yashoda. And just like going back in history, that one case I distinctly remember, it was, I think 1996 or 1997. And that mother had an antenatal scan done in private setup. There was diagnosis of gastroschisis. And I remember that the mother had a cesarean section in one operation theater. We were still working in the main theater at that time. And we did the closure of the gastroschisis within like half an hour. The baby was received and the baby was taken to the operation theater, and we closed that baby's gastroschisis, I believe primarily. And that baby had necrotizing enterocolitis within a couple of weeks of closure of the gastroschisis, but everything went well. And obviously, because it was a paid delivery in the hospital and immediate closure, there was hardly any peel, no edema of the bowel, and that really helped with the recovery of the bowel and further recovery. And surprisingly, about 5 years ago, I received an email from this young lady who is doing some university course in computer sciences. So I think we just need to remember and emphasize that this is a mechanical problem. It can be corrected or repaired, and the child will have a normal lifespan. So that is something which we need to emphasize on the minds of other colleagues. I think, Sello, it has been a fantastic meeting. We have had the maximum attendance for the meeting. I mean, at one stage there were 43 attendees, we are really blessed about it. So I would just like you to conclude and a take-home message, mainly for the junior and the trainee doctors attending from all over the world. So your final message, and then we will conclude.
Thanks, Prof. A part of me wishes someone in admin was listening, who develops policies, so that we can tell them that actually teaching people how to do adequate ultrasound and being able to intelligently diagnose gastroschisis will not sort out our problems, but it will help quite a lot with this problem. So that's extremely important. And for the junior shame, there's lots of ways to handle something. The best way to handle it is with confidence and with care and meticulously. Don't handle something. You try not to be butchers, or hopefully you're not butchers. But if you're very gentle and meticulous in handling a child with gastroschisis, with the bowel, with the making sure that the child is warm, making child with IV fluids, the outcome can be good. And it's a scary thing, Shane, when you are faced with it for the first time, where you have no idea what to do because you're unfamiliar with it. But if you calm down and realize that, it's just bowel, let me just cover it, make sure that it doesn't lose heat, and let me not put gauze on it, which John alluded to, that people still do to this day, and put plastic and send the child in a stable fashion. That will definitely help having a good outcome. But we'll see going forward. Definitely, if COVID is a factor, definitely it's something worth looking into. Do some maternal bloods and see even the child if there's in mutual transfer. That'll be fantastic to see that. But ultimately, we want to decrease the mortality of gastroschisis, and the only way you can do that is through knowledge and information. And the wider we disperse the information, the better the outcome will be for the kids. Thanks, Bob.
Thank you very much, Sello. It was really excellent teaching, learning, and discussion. So I thank you again. And next week, we will have a talk by Dr. Wilna Thibaut. She is a specialist pediatric surgeon in private practice in Durban, South Africa. And she's going to give us a talk on precocious puberty. So the invite will go out soon, and we would welcome all of you and your colleagues who are able to join us same time next week, Tuesday, 21st of September, for our Zoom academic meeting. Thank you very much. Have a great day wherever you are. Thank you again. Bye-bye.